The listening part of occupational English test has 3 parts, and in each part you hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Mrs. Brigi. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, I have headache. The headache first began 2 months ago. I feel a sensation of pressure. The intensity is moderately severe, making regular activities difficult. I fear I am getting much closer to sinus congestion, or maybe photophobia.
What's your age?
42, doctor.
Do you drink or smoke?
Well, I do not smoke, but I drink regularly.
Tell me if any of your family members have any history of illness.
My father and brother have a history of migraine, doctor.
Is there any congestion in your chest or throat?
Yes, I have some sinus congestion.
Did you have any cardiovascular problems?
No, doctor.
Any gastrointestinal problems in the past or present?
No, doctor.
Are you taking any medications?
No, doctor.
Are you allergic to any medicine?
Yes, codeine.
Do you have any muscle cramps, joint pain, back pain, or limb pain?
No, doctor.
Do you have any musculoskeletal problems, or in the past?
No, doctor.
Well, the sense of smell of your cranial nerves was intact. Neck range of motion was normal in all directions. There was no evidence of cervical muscle spasm. No radicular symptoms were elicited by neck motions. Shoulder range of motion was bilaterally normal. There were no areas of tenderness. Tests of neurovascular compression were negative. There were no carotid brutes. Back range of motion was normal in all directions. Position and vibratory sense was normal. Your gait has no abnormal components. Tandem gait was performed normally. There is no edemia or significant varicosities. You have developed migraine without aura. I am going to describe therapeutic trial of Inderal 40 milligrams, half tablet twice a day for 1 week, then 1 tablet twice a day for the next week, and then for the third week, 1 tablet thrice a day. Continue these medications for 3 weeks and meet me again after 3 weeks.
Now look at the notes for Extract 2. Extract 2, questions 13 to 24. You hear part of a consultation between a neurologist and a patient called Peter Jackson. For questions 13 to 24, complete the notes with a word or short phrase.
Morning, Mr. Jackson. Now, you've been referred to me by your GP, and I'm the first neurologist you've seen, I think.
That's right. I think my GP's got some ideas about what my problem may be, but he sent me here, to double check.
Okay, I've got some notes here with his referral letter, but it'd be helpful if you could tell me in your own words the symptoms you first noticed.
Well, there were several things which started early last year. They don't sound too bad individually, but together they were affecting me quite a bit. I guess the worst thing was, well, feeling absolutely shattered, feeling exhausted most of the time, even when I'd not been doing much. I'd never suffered from depression, but I started feeling a bit down. There wasn't a specific trigger.
And any physical pain then?
Well, my right leg, it didn't ache exactly, but there was a real stiffness, which made walking slower. And my neck was affected too. Again, not a pain, but more like a tightness. Yeah, that's how it felt, and it still does. I started to get constipated too, and I'd never had a problem with that before.
I see.
And I noticed other things around the same time, like my handwriting. I used to write strong, big letters, everyone always said how distinctive it was. But it was shrinking. Weird how it had changed. I'm right-handed and I began to notice from time to time there was a spasm in that hand. It didn't happen often, but it was worrying. The worst thing though was something I noticed when I was in its standing position. Washing up or shaving. I'd suddenly feel really unstable on my feet.
That must have been frightening.
Yeah, I was always scared of toppling backwards.
And I gather you've recently started to experience other symptoms?
Yeah, this last month or so. It's funny, I used to love cooking, testing out different ingredients and stuff, but my sense of smell's just gone. I don't like preparing meals nearly as much. Then, something which drives me mad is that I keep forgetting things. I used to have such a good memory, and the really frustrating thing, especially for someone who was never exactly quiet, is that people keep on asking me to speak louder, but I just can't seem to raise the volume now. My mouth feels full of saliva too. It seems to build up more, so I'm wondering if that's got anything to do with it.
Any physical activities you're finding hard?
Oh yeah, driving's hard, so I don't use the car anymore. I can still use keys to lock doors, though sometimes it's tricky. But buttoning up cardigans and shirts is impossible now. It's so fiddly. I'm getting an electric toothbrush too, 'cause the manual one's so difficult. I'm ashamed to admit my wife insists on cutting up my food too when she sees me struggling, especially when things like, steak.
And you went on to consult other GPs?
Yeah, I saw two doctors in the same practice for a second opinion. The first mistakenly thought it was a trapped nerve, and the next sent me for physio, saying it was probably a frozen shoulder. That was wrong. So he then thought it might be carpal tunnel syndrome affecting my wrist.
They were just investigating possible causes.
Yeah, fair enough. And I'm hoping it's nothing serious. I mean, I don't think it's a brain tumor or anything, but I have started to worry that it might be multiple sclerosis. Given the symptoms, then my granddad had dementia. I desperately hope it's not that.
I don't think so. And looking at the tests you've had, a blood test and...
A thyroid functional test. But I never heard anything back from that, so I'm assuming it was negative.
Okay, well, I'm going to look at your notes again.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a monologue by a physician explaining to his staff about Bacillus coli. Now read the question. Bacillus coli is an intestinal protozoan parasite that can infect human beings, which are transmitted through the fecal-oral route by contaminated water and food. Although Bacillus coli infection is mostly asymptomatic, patients with other severe illnesses can experience abdominal pain, persistent diarrhea, and sometimes a perforated colon. Bacillus coli is a parasitic species of ciliate alveolates that causes the disease balantidiasis, which is the only member of the ciliate phylum known to be pathogenic to humans. Question 26. You hear a monologue by a physician explaining to his nurse about Hansen's disease. Now read the question. Hansen's disease is caused by slow-growing bacteria called Mycobacterium leprae that affects the nerves, eyes, skin, and nose lining called nasal mucosa. The disease can be cured with early diagnosis and treatment. Hansen's disease was once considered as a highly contagious and disastrous disease. However, today we know it doesn't spread easily and there are effective treatments. If left untreated, the nerve damage can result in crippling of feet and hands, blindness, and paralysis. In very severe cases, the patient may have multiple injuries due to the lack of sensation, and eventually the body may reabsorb the affected digits over time, resulting in the apparent loss of toes and fingers. When the disease affects the facial nerves, corneal ulcers and blindness can also occur. Other signs of severe Hansen's disease may include loss of eyebrows and saddle nose deformity, causing damage to the nasal septum. Question 27. You hear a physician discussing Japanese encephalitis and its risk factors. Now read the question. Hello, doctor. What is Japanese encephalitis and who is at a higher risk? Japanese encephalitis is a serious infection caused by the Japanese encephalitis virus that occurs mainly in rural parts of Asia. The disease is mainly spread through the bite of an infected mosquito. However, it does not spread from person to person. The residents where the disease is common or the people who travel frequently have the higher risk of this disease. Most of the patients do not develop any symptoms. Patients with Japanese encephalitis experience fever, neck stiffness, seizures, and coma. The disease has a mortality rate of 1 out of 4 patients. 50% of the patients have permanent disability. It can even harm the embryo of a pregnant woman. Question 28. You hear a physician talking about epilepsy and seizures. Now read the question. Doctor, what is epilepsy and what is a seizure? Epilepsy is a neurological or brain disorder which is also called a seizure disorder at times. Often, the patient is diagnosed with epilepsy only when they have already had 2 or more seizures. A short change in normal brain activity is called a seizure, which is the main sign of epilepsy. While certain seizures appear like starting spells, other seizures cause the patient to fall, shake, and become unaware of what's happening around them. Generally, a seizure lasts up to a few minutes depending on the type of seizure. Generalized seizures affect both sides of the brain, and focal seizures or partial seizures affect one side of the brain. Question 29. You hear a physician discussing about Lyme disease and its consequences. Now read the question. Hello, doctor. What is Lyme disease and what are the consequences of it? Well, Lyme disease is caused by the bacterium Borrelia burgdorferi and is transmitted to humans with the bite of the infected black-legged ticks. Typical symptoms include headaches, fever, fatigue, and a characteristic skin rash called erythema migrans. Infection can spread to joints, the heart, and the nervous system if left untreated. Generally, Lyme disease is diagnosed by its symptoms and physical findings, such as the rash. Laboratory testing can be precise only if performed appropriately with validated methods. With a few weeks of antibiotics, the disease can be treated successfully. Question 30. You hear a physician explaining to his nurse about Omsk hemorrhagic fever. Now read the question. What is Omsk hemorrhagic fever, doctor? A member of the flavivirid virus family called Omsk hemorrhagic fever virus causes this disease. The disease was initially detected between 1945 and 1947 in Omsk, Russia, from patients with hemorrhagic fever. The primary host of the disease is the rodents from the bite of an infected tick. Common tick vectors include Laxodes persulcatus, Dermacentrum marginatus, Dermacentrum reticulatus. Common rodents infected with the disease include the muskrat or the Andrada zibethica, water vole or Arvicola terrestris, and narrow-skulled voles or Microtus gregalis. However, muskrats are not native to the Omsk region, but were introduced to the region, and now they have also become a common target for hunters and trappers. Muskrats become ill and die when infected with the virus. OHF occurs in the Novosibirsk, Western Siberia regions of Omsk, Tyumen, and Kurgan.
Part C. In this part of the test, you will hear two different extracts. In each extract, you will hear health professionals talking about
For
specific
questions from
aspects of their
31 to
work.
42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at the extract 1. Extract 1, questions from 31 to 36. You hear the doctor briefing his juniors about different types of chest pain in female patients. You have 90 seconds to read the questions from 31 to 36. Chest pain is one of the common health issues from the patients in medical OPDS that causes a lot of anxiety in the patient as it is often connected with a heart attack or angina, and people are well aware of the severe consequences of the symptom. However, a chest pain is not necessarily caused by or originating from the heart diseases. There are numerous other structures in the thoracic cavity. Therefore, a systematic approach is crucial to arrive at the correct diagnosis causing the chest pain. A chest pain in menstruating females has a great significance, as they are less liable to get heart diseases until menopause. Estrogen prevents the development of atherosclerosis. Coronary artery disease or myocardial infarction is very rare in menstruating females. As menopause approaches and estrogen levels decrease, the chances of development of coronary artery disease increases. Reversible loss of blood supply to the heart muscle called angina pectoris or cardiac pain is retrosternal, poorly localized, vague, heavy, squeezy feeling, compressive. Angina pectoris rarely lasts for less than 1 minute or more than 20 minutes. Unless it is a heart attack, patients are relieved in less than 5 minutes on the use of sublingual nitrates or cessation of all activities. Angina pain can also occur in the left arm, left shoulder, the jaws, or neck. Sudden blockage of an artery supplying blood to the heart muscle, called myocardial infarction, would be similar to this but very severe and lasts longer. The pain will not be relieved by sublingual nitrate or rest, and the symptoms are palpitations, nausea, vomiting, perspiration, blackout, dizziness, or even mortality. Pain that is unlikely to be of cardiac origin is often well localized, lancinating, prickly, sharp type lasting for less than 15 seconds at times. It can also be an aching type but mostly will be aggravated by coughing and deep inspiration. Often, the patient will be able to localize the pain with the tip of the finger. However, the pain that is localized just below the left nipple will never be from cardiac origin. Common causes of chest pain in young females. Mitral prolapse is a common and benign condition. Leaflets of the mitral valve are lengthy, redundant, and bulky. They prolapse into the left atrium during systole. The causes of this pain are unknown. The pain occurs at rest, non-radiating, prolonged in duration, and sharp. Mitral stenosis or rheumatic valve disease is a common rheumatic condition in females and can cause dyspnea and chest pain. The patient will have symptoms like expectoration, a cough, and there would be low-pitched rumbling diastolic murmur that will clinch the diagnosis. A 2D echocardiography will be confirmatory.
Now look at Extract 2. Extract 2, questions 37 to 42. You will hear a clinical pharmacist called Emma Royce giving a presentation about the side effects of certain types of medication. You now have 90 seconds to read questions 37 to 42.
My name's Emma Royce, and today I'd like to talk about some unanticipated side effects of certain widely used medications. The side effects that I'm particularly interested in involves changes in a patient's behavior, in particular, the onset of what's known as compulsive or pathological gambling in patients suffering from Parkinson's disease. Pathological gambling is essentially an addictive disorder in which the patient feels a need to engage in financial risk-taking in the expectation of gaining a reward. It is characterized by both recurrent and persistent behaviors and can lead to significant distress and the breakup of personal relationships. The condition is thought to affect around 1.4% of the general population, a figure which rises to 7% in Parkinson's patients. It was this finding that led to the realization that there was a link between the medication prescribed for that condition, notably dopamine agonists, and the onset of pathological gambling. So, how common is this side effect of Parkinson's medication? On the surface, it would seem that it remains the exception rather than the rule, only affecting around 1 in 7 users, and not all of those in a severe way. Also, because only a small proportion of patients treated with dopamine agonists develop the symptoms, it may reflect specific predisposing factors. The exact level of incidence is unknown, however, and this may be because many cases go unreported. Patients themselves or family members don't admit to the condition out of shame, or because their doctors or carers haven't been able to identify it. And this could explain why it doesn't show up more frequently in pharmacovigilance reporting systems. Let me give you an example of a typical case. A 74-year-old male, let's call him Harry, who was diagnosed with Parkinson's disease and prescribed the dopamine agonist pramipexole. About a month after commencing treatment, he began to feel an increasing need to play slot machines until he was going to a gambling venue every day. At first, Harry was able to conceal his behavior from family members, another common feature of the condition. His wife did notice other symptoms. Harry was having difficulty sleeping and wasn't finishing his meals, but she put these down to his Parkinson's. It was when Harry began impulsively buying items that he neither needed or wanted that his wife became alarmed. It was at this point that the hole in his bank balance caused by the gambling came to light, and the couple was able to seek help. In other cases, heightened sexual activity has been identified as an indicator. There are several underlying risk factors for developing pathological gambling: male gender, a previous or family history of gambling, personality traits such as high impulsivity and high novelty seeking. The risk increases when such people take dopamine agonists as treatment for Parkinson's disease. Originally, research suggested that the higher the dose, and the longer the duration of the prescription, the greater the likelihood of compulsive symptoms occurring. More recently, however, research into the use of the medication for another condition, restless leg syndrome, or RLS, has shown that symptoms can develop even at low doses. So, what are the long-term effects of these adverse reactions? Pathological gambling seems to be reversible when the dose of the dopamine agonist is reduced, or the patient is transitioned to an alternative medication. Basically, dopamine agonists help Parkinson's patients by replacing the loss of dopamine in areas of the brain that control the ability to move. But the increased dopamine levels then affect other areas, such as the neural system linked to pleasure and reward behaviors and associated emotions, which then manifest themselves as impulsive and compulsive actions. But the effects are not long-lasting. Harry lost all interest in gambling within a month of stopping pramipexole therapy. But sadly, for many patients, the problem isn't picked up before life-changing disruption is caused, as significant gambling debts develop and relationships become strained. So, what can we do to improve the management of these side effects? There's no doubt that Parkinson's is a serious and degenerative disease, so the drugs may represent a reasonable trade-off in terms of risk-benefit analysis. It's hoped that by educating patients and carers about potential side effects, it'll make them more willing to report changes of behavior. Patients and their carers should be monitored closely for the symptoms, so that as soon as any side effects do emerge, the drugs can be tapered or discontinued. For other conditions, such as RLS, however, it is open to debate whether the risks associated with compulsive behaviors outweigh the therapeutic advantages of administering the medication. What is needed is further research to establish just how extensive the problem is.
That is the end of Part C. You now have 2 minutes to check your answers.